Thank you very much for the introduction. Let's skip this one because that was just to water your mouth before we would get into real presentation. So bladder en bloc dissection is a new way to understand and to actually harvest and get all the information we need for surgery. And why do we have to evolve? It's because what we used to do was not good, period. And that was very neatly demonstrated 20 years ago by Professor Browsey from different control arms of EORTC studies, showing that the quality of TURBTs was indeed impacting the outcome of the management. And how did he demonstrate that? Just by showing that between academic centers, stage by stage and grade by grade, the odds of recurring varied from 1 to 7. Meaning that in some places you were almost insured to recur, and in some others you very rarely did. From that time, there was a huge dynamic in bladder cancer, which is certainly at the moment one of the most rapidly evolving fields of uro-oncology. And among all the different concepts that were developed during that time, one of those was en bloc surgery. Why en bloc? Because it is the TURBTs, piecemeal resection of the bladder, was the only oncological surgery where you would actually fragment the tumor before removing it. It's one of the oncology principles that we should never actually fragment the lesions, not only because it can lead to local seeding, but possibly also to circulating tumor cells being produced. So therefore, it has been some sort of discussions and fights between two systems. The old-fashioned system that is piecemeal fragmentation of the tumor, and then you recover the chips. It leads to a lot of difficulties for the pathologist to establish the grade, not the grade, but the stage, or the en bloc surgery that was initially developed in Japan in the 80s. There are solid benefits for the en bloc, and this is not here today. I'm not here today to develop those, but those benefits are mainly related to the safety of the surgery, because you follow a plane of dissection instead of cutting through and you don't know what you're doing, and also in the quality of the specimen that you harvest for the pathologist. So therefore, the pathologist gets the best possible elements to establish the stage, and even to some extent establish the margins, or the status of the margins of resection. So in a very simple words, what is en bloc TURBTs? It's you follow a plane of dissection, you do a prograde dissection, it's not a retrograde. The energy that we apply, I'm using a bipolar system, a plasma kinetic system. It's not a continuous activation of the section, but it's this burst of energy, staccato, bit, bit. And you can combine sharp, I cut, and blunt. I slowly dissect, follow my plan of dissection. And also the loop itself is used in a different way. When we were piecemeal resection, it was just bjit, and sometimes we were super courageous and we would do bjit. And now with the circling around, doing transverse dissection, sagittal dissection, sharp and blunt. So we can do almost anything or everything with this innovative handling of the loop. Just a few slides. So how do we do that? How do I do that? First, you do a preemptive coagulation of the margins of the lesion that you want to resect. That will reduce the blood loss, which is very minimal with this technique, and also allow you to know exactly how far you want to do your surgery. You know that when you start engaging in TURBTs, the most complicated part of it is actually to be certain at the end of surgery that there is nothing left remaining. So you have to know, and actually to take advantage of the quality of the vision you have at the beginning of the surgery to delineate the extent of the optimal surgery. Second, you have to do a controlled incision cutting of the bladder wall so that you will be right in the right plane. You may be mucosal, never get into the detrusor muscle. That is what's recommended. You can even perform a very aggressive TURBT that would actually do a transmural resection of the lesion that can be of some use in small PT2 lesions. Second, when you have cut and delineated and cut, you just follow the plane of the smooth muscle bundles. Using the new endoscopic techniques, those are visible like big whitish bundles of tissue. So we just have to remain above that, and you're absolutely certain not to perforate the bladder. And at the end, this is exactly what happens. As I say, this innovative techniques was instrumental in reorganizing the landscape of non-muscle invasive bladder cancer management. And I would like to start with one very simple TOVT. The video takes 3 minutes. I always start those with a flexible, because a video flexible, because this is the best way to understand the landscape and to organize your mind and to organize your strategy. What I would like you to convey to you is TURBT is not one single surgery. It's actually hundreds of different situations that have to be taken care. And the best way to organize your strategy is to have the best vision at the beginning. And this best vision is, to my mind, obtained using a flexible videoscope. You can complement white light imaging with narrowband imaging as it was done here. There you can see that using NBI, but you also have the same system or some other systems from Stolz that would do the same, that allow you to exactly pinpoint the limits, the margins, superficial margin of the lesion. As I said, you initially decide how deep you want to go. So it is incision, it's not fragmentation. So you incise, and immediately you'll see that a plane will slowly develop. And this plane can be followed by sharp staccato incision, or by blunt dissection. I just push forward. As you've certainly understood, in that case, the challenge was position of the lesion. We know the tumor, we know where it is, it doesn't look too bad, but it is not ideally located within the bladder because it's actually stuck onto the left ureteric orifice. So the dissection, the objective of dissections will be to do your dissection, to get underneath the terminal part of the ureteric orifice, to identify this terminal part, and then using section to transect it. Section, and of course, with minimal use of the coagulation, because you want to avoid as much as possible having a stenosis. Again, using plasma kinetic energy, bipolar energy, you produce many, many, many bubbles. Those bubbles tend to float upward, and therefore it will be important for you to keep in mind that you have to position your loop and make the surgery slightly more difficult. This, as you can see, the surgery is being done under narrowband imaging. Of course, it can be done also, and it is amenable to white light imaging as well. So, okay, do we have anything else to say? Looking for the terminal part, and then when you are satisfied with the dissection, you do the transection of the terminal part of the ureter, and there it is. We have to use the coagulation sparsely, so as not to avoid to spoil and to decrease quality of the specimens. This is why it is important to delineate your lesion before engaging into your TURBT, because it's so easy to follow. And ultimately, you resect too much normal tissues around there. Okay, so simple surgery. Follows the general rules of oncological surgery. I see, I cut, I do prograde, and I control my plane of dissection. Actually, it leads to this kind of information. You have a sample that is organized. I'm very keen on pinning it on a board so that the pathologist will get a sample that is absolutely optimal for analysis. I usually put some ink in the as you can see, so she'll even be able to tell me what are the margins of this surgery? Am I in positive or negative margins? Sometimes you do this en bloc and you end up with this information. This is an en bloc specimen. It's quite easy to see that you have an infiltration of the lamina propria. Therefore, it's a T1. We know that the guidelines insist on the fact that T1s, we have to redo the surgery. We have to ask ourselves, why do we have to redo the surgery? Well, first, because the first surgery wasn't too good, and this is a table that you have over there. And second, because if there was the initial surgery wasn't optimal, what we need to look for as an information is located beneath the scar of the initial TOBT, meaning that redo or re-TOBTs for T1 is a complicated surgery because you have to go deep. You have to almost perforate the bladder. If you have a T1B, you have to go extremely deep to ascertain the quality of your initial resection. And this is a repeat en bloc. So the patient had received the first surgery 6 weeks before. And again, the bladder is not too inflated because you don't want to over-distend it and to make it thinner than necessary. And the question is, the first point is, I need to go deep enough. There I just cut the mucosa. That's not deep enough. I have to start a few millimeters away from the scar because I want to go under the initial scar. And this is the anterior part of the bladder, and therefore I don't want to go too deep because I'm a bit anxious about the rest of the surroundings. So you cut again. You always manipulate and think about and remember that the bubbles might be caught by your system. And all of a sudden, you will see that there, the right plane of dissection is reached. And at that time, it will be again a piece of cake to follow the plane of dissection. If I had one point to stress today, it is that as opposed to piecemeal resection, piecemeal fragmentation of the tumors, we are following planes of dissection. We know what we're doing. We can identify whether we are in the superficial detrusor, if we are beneath the detrusor in the periphysical fat. It's easy to do, and it's very informative. Again, JIT. And as soon as you have found the plane of dissection, you just follow it. What I'd like also to insist on is that they are all the same basic movements. I see, I cut, I push, I lift, therefore, a bit the tumor. So therefore, I develop the plane. I see the position where I want to cut, I cut, blah, blah. And this is always repeated. One thing that also is of interest is that the surgery, the strategy for the surgery is highly dependent on the position of the tumor within the bladder. You won't do the same surgery for an en bloc dissection of the trigon lesions as opposed to a lesion of the dome or to a lesion of the anterior part of the bladder. You have to design your own technique. Today, we just have 15 minutes, so I'm also sorry not to be able to share all the tips and tricks, but it is a surgery that is super exciting because you have to adjust yourself to the complexity of the surgery. Not the same thing to have something that's 3 centimeters wide or 1 centimeter wide. Not the same thing to have something that is close to the obturator nerve or located on the uretary orifice. So instead of having one surgery, you have a myriad of different situations that you have to cater. So you got the system, JIT all the time. I also had a final video where I'm doing a transmural dissection, meaning I'm cutting through the bladder wall for a small T2 lesion. But for the sake of time, as soon as this one is finished, I'll conclude and leave the podium to my friends. So if you have any questions, maybe it's a time to ask them.
Bernard, do you, for the difficult to remove tumor, do you have any device that you use?
No, I'm working in France. not in British Columbia, so therefore I don't have that much at hand. So we have a rule of thumb saying that anything that is smaller than 2 centimeters can be removed by grasping it with a loop at the end of surgery and extracting it through the external sheath of the resectoscope. That is simple. Up to 2 centimeters, easy. 2 to 3 centimeters does depend on the softness of the tissue. When it's creamy, soft, not too complicated, but you have to, when you grab it, to grab the foot and not to grab the fronds, because the fronds will be extremely fragile and will actually fragment and shed cells everywhere. When it's larger than that, the good trick is at the end of the surgery to leave the specimen loosely attached to the bladder wall. So you do not sever it from all its attachments, so it is still stuck on the wall. And you use a Collins knife, for instance, to split it into 2 pieces. 2 weeks ago, I was visiting in Copenhagen, and they asked me to do 1 surgery. Of course, they selected a nice one, and this one was huge. And this is exactly what we did. You split it into 2 pieces, and then you just use the same system. Alternately, when the lesion is extremely bulky and you're a bit worried about that, you can also destroy or vaporize the surface of the fronds, because the fronds bring only one information that is grade, and you just need to have 1 sample to get a grade. And then you engage into your en-bloc, and you benefit from the safety of following a plane of dissection. That's an alternate solution. It's also possible for those of you who have a nephroscope to use a nephroscope and then a tripod forceps to extract large tumors. And when you do that, it's always the same thing. Always good to let the sample loosely attached to the bladder wall so that you can actually select which part of this floating medusa you want to catch. And this part must be the most robust one, that is a foot, that is the pedicle, not the front. Fronts are of the fact. And there you see that finally we got it. And we have some yellowish tissue all around. And this, by the way, this video wasn't cut. So it is said that en-bloc is a bit longer than a fragmentation, no doubt, 30% longer, but this was done in 7 minutes, so well, we are not too much, too far from what you could do with a fragmentation. Last, possibly, I do love to use the loop to vaporize the mucosa around it at the end with a no-touch system that I'm quite eager to show you. And that's the most important slide. Most important slide. This is Toulouse. And Toulouse is the south of France. University is quite home. City is very nice. And we are very extremely friendly people, and you are all welcome to come. Thank you.